Top Med Talk. Good morning and welcome to Day 2 of EBPOM-USA, live from Atlanta, Georgia in the USA. This is the first Perioperative Medicine Practicum. I'm Monty Mythen. I'm joined this morning by Desiree, Chappell and Mike Grocott. So Mike, you opened yesterday morning. Some reflections on yesterday.
Lots of enthusiasm in the room. Very exciting to have the first EBPOM-USA meeting here in Atlanta. The first session, very much big picture stuff. A lot of talk about the money, which clearly drives behaviour in different ways in different environments. And then a really interesting session on fluids and analgesia later in the afternoon.
So on the money section, myself and Desiree recorded a piece with Vicky Morton and Lee Fleischer last night, where we went into quite a lot of detail about that session, with a lot of the abbreviations, MACRA, MIPS, these various different drivers, the Maryland experiment. Now, do you think we talk about the NHS, we talk about it as sort of a single-payer system, and we're a long way into this sort of bundle payment idea. Does that really help us? Is it easier for us to do things compared to what you were hearing from Lee? Do you get that impression, or it doesn't really matter?
It seems to be a little bit of a complex picture, obviously. So I work in the NHS environment. I'm familiar with the American environment from Duke. If it's something that's going to make money, it seems to be pretty easy to do over here. So if you can attach an income source to it that is your own, then it seems to be pretty easy to do. If it's not, then it seems to be much, much harder to do. And I get the impression that the method of budgeting within the NHS is such that we can realise some of the benefits that accrue to patients that may not more obviously fall to a particular specialty group. So the silo issue that we talk about a lot in the NHS actually is probably more of a problem over here, because people are worrying about the money coming to their group, and that's sometimes a disincentive to doing the right thing.
We went in more detail last night again about this Maryland experiment, and it seems as though that state has got to a point whereby it's much more like the NHS. It's the closest thing it would appear in the USA to the NHS. And I asked Lee about where they are in the league table, and I think he said that they were these are hard things to judge. If anything, their position has improved in the league table and their results. So things have not got worse. If anything, things have got better. Desiree, is that what you took from that conversation?
I think that it just shows there's a transition anytime you're trying to change the model of care, and that if you can work through the transition and come out on the other side of it, there'll be a benefit. But there are growing pains with it that you have to realize.
Did you get the impression it was an experiment that was probably going to result in widespread adoption of that model, or did you think it was not certain yet?
Yeah, I think it's not certain. I mean, it's a great learning experience, but I think there's still a lot of people to convince that that's the right model to go to, on a national scale.
The other thing I was taken by, which also went into detail, was the fact that bundled payment for some people is a great success, and some people are choosing to opt into the bundle. Were you surprised by that, Mike?
No, I found that very intriguing, but that certainly was the message that I got from the presentations, that actually people were preferring to work into that environment, and the environment that was going to be created was a voluntary opt-in approach.
So as a consumer, now I've heard all of those discussions. If I was in the USA, I have to be careful what I say here, I'd want to buy off someone who is doing a bundle, because they have got to a position whereby they've managed to make a good margin by providing quality care out of taking the median price for everybody else. So it strikes me that's the place to buy your healthcare is in a bundle shop, because they also have to accept within that bundle the cost of the morbidity out for a number. Am I crazy there, Desiree?
I'm not. It makes complete sense, but the problem is, I think as healthcare consumers, we're not there yet to even understand that there's a difference. I mean, the people that I work with in Kentucky are not well educated on what their options are, and until that's more of a prevalent system, I just don't think people are going to even know that they need to choose that way.
Right. So for those of you who just joined us, welcome to Top Med Talk, live at Day 2 of EBPOM-USA here in Atlanta, Georgia. And we're just having some reflections on yesterday with Desiree, Chappell and Mike Grocott. You mentioned in the afternoon session there were some discussions again about pain relief. Now, the three big topic areas that Top Med Talk's chosen for this year is brain health, which we'll be coming back to later in the day, hemodynamics, and the opioids, or what's commonly referred to as the opioid crisis. Some takeaways from the session yesterday afternoon that Desiree was in.
I think the two main messages for me was that things are moving on in the US. There's the regulatory environment at state level is changing such that there are now restrictions, that the number of days of opioids that you can take home. That seems like a very positive thing. And there was a lot of talk about alternatives to opioids. And for whatever reason, the session yesterday was very much focusing on some of the potential adverse effects, some of the controversies with surgeons, for example, around non-steroidals and anastomotic breakdown.
So we were told in the afternoon that non-steroidals are one of the few viable alternatives, direct alternatives to opioids when pain really gets quite bad in certain circumstances. Now, I don't sense we have as many concerns about the side effect profile in the UK. I think we're very attuned to acute kidney injury, i.e. we don't give non-steroidals to people who have pre-existing renal dysfunction, and if we do, we watch it very, very closely. But the anastomotic breakdown, I've heard it mentioned, but it doesn't seem to be a big ticket item.
I don't hear that as a major concern in the UK. I mean, similarly, the bone repair story, there are, I know of a handful of orthopaedic surgeons who have concerns about that, but I would characterise them as relative outliers.
Desiree, were you surprised to hear all of that?
No, I mean, those are all typical questions that we get frequently when people are asking, what do I need to use? How do I build the protocol to include the different modalities? But I don't think it's that much of an issue. I think sometimes it's a fleeting way for people to be a little bit resistant when they want to change. They kind of come up with those things, but as soon as you show them the literature or lack thereof, then it kind of passes and they move on. So
one of the things we were suspicious about with the introduction of enhanced recovery in the UK is one dangerous setup is if you, for the fluid management, you decide to restrict, and now you add in around the clock non-steroidal. So you've now left somebody dry, potentially seriously dehydrated. Maybe you've bumped their creatinine already. You don't have a very well perfused anastomosis now, and you add in a non-steroidal. That sounds like a setup for believing the non-steroidal drove the two other things. Am I crazy, Emma?
Not at all. And I think we saw it was more striking in the elective orthopaedic area, but we saw filtration on the intensive care unit following an elective hip or knee replacement for the first time in years.
And I've never seen that.
In the aftermath of enhanced recovery. Now I think we've sort of moderated back to a more sensible path, but that risk is there.
I mean, I've actually talked to anesthesia providers, and asked them what their how they drive fluid therapy, and they're in the restrictive model, and asked them specifically about the AKI question, and like, oh well, we give the meds that we give you'll see a little bump in their creatinine, so we're not too worried about it. I mean, I've heard that quite often actually traveling around, so I think that it is maybe an opportunity to have that discussion later on with those providers about the fact that you may see a bump in your creatinine, but if you're drying them out, it's definitely going to take a double hit there. So, and
epidemiologically, the little bump in the creatinine, it does not appear to be a benign phenomenon.
No, I think from what we know about post-operative renal impairment, if you get a little bump, you're more likely to get long-term renal harm. And we may be more of a player in that than we would appreciate.
So that overlaps then that discussion. So great progress we hope in everywhere in trying to see what our contribution to get to helping with the so-called opioid crisis, in particular reducing the meds taken home, that overlapping with this non-steroidal and the fluid management issues. Now, Desiree, yesterday morning we were in a hemodynamic workshop, which the first one I've done of that sort, which was a simulated workshop, lots of discussion. Some reflections on that? Yeah,
it's a great success. I think anytime that you're engaging everyone in the conversation, and the case studies that you did, and walking through and what would you do. I mean, I think it's a great idea for people to think through it themselves and put themselves in when they're in that situation, to be able to take that back with them and actually apply it. I think there was a lot of great discussion around what would you choose, how would you treat. That made people maybe think twice about what they reach for when they're on the stool.
And we did have a reasonably heated, in a positive way, discussion about the choice of fluid. And again, we have to reflect, even though there are strong emotions about this, the colloid crystalloid thing, it remains a known unknown. So we don't know the answer to that question, which means we can't definitively say one way or the other, which means we can't say that the cheaper is better than the more expensive. we just don't know.
That's my reading of the literature in the perioperative setting. I think high volumes in critical care. There's a reasonable case for not throwing starches in particular at people, but in the perioperative setting, to balance that, we've got the optimization literature, which appears to suggest that a more carefully titrated dose is potentially a benefit.
There are a number of people in the room who suggested they were still using colloids for their fluid boluses, and part of that was just differentiating the Desiree on that?
No, yeah, I mean, I think that it's one of those things that you just have to pick something and go with it and standardize what you're doing. And I feel that, I mean, we use colloids to bolus, and we've done that from the beginning once we started it. And it's worked for us, and we're sticking with it.
Is part of that because you think the colloid's secret sauce, or you know that drug is for the volume?
Yeah.
The former or the latter? Is it because the mindset says I'm now giving volume, if you sort of mean, as opposed to giving maintenance?
Yeah. I mean, it's definitely the bolus.
It's notable to me that even in the optimization studies where there isn't an overall benefit in terms of mortality, the renal injury or the reduction in renal injury in the optimized group seems to be a very, very consistent pattern.
So in the Fedora trial, which we've done a special piece for, we referred to a number of times, this latest multi-center randomized control trial from Spain, they gave 6% hydroxyethyl starch for their optimization algorithm. That's one of the reasons they had to stop the trial, because of the fears of it being associated with acute kidney injury. And that group had less acute kidney injury.
Which is consistent with the bulk of the literature.
Which seems to be much more about how you do it rather than what you do it with.
Yeah, and I don't know the exact doses in that study, but I would imagine the dosage levels are not those that one would be getting alarmed at in terms of renal harm.
Not at all. I think the median was 500 mils or something, so it's well within the levels where people might be thinking there's some concern in there. The other takeaway from that session was the discussions. The hemodynamic session was the literature is continuing to move towards the idea of, rather than just fluid management, it's hemodynamic management. i.e. some patients need some squeeze, some people need increased pumping action from the heart, they need more contractility, and therefore vasoactive drugs need to support that. And in one of the trials, a norepinephrine infusion was used through a peripheral vein, and some people in the room said that was acceptable in their practice in the USA, whereas some people seemed to be completely shocked. It seemed to be as though the world would come to an end if they tried to start a norepi infusion. Is that right, Desiree?
Yeah, I do. I mean, but I just think it's the culture. I mean, whatever. You're always going to balk at what somebody else is doing that you're not doing and that you think's wrong. I mean, I just think that we all practice in our little silos and don't really talk about what other people are doing. And if you're not looking at the literature, you're just going to stick with what you have, which I think happens.
Was it transpired that you're allowed to give dopamine infusions peripherally and nobody would bat an eyelid at that? That's kind of it. That's like a cool...
the peripheral thing. Yeah, that's true. But I don't know. I mean, I think that our ICU doesn't ever have a problem giving norepi through a peripheral vein.
Okay, and that seems as though many people in the room were comfortable with that. And Mike, your thoughts on that?
So we very much have the culture that norepinephrine central line. Yeah. To my shame, I don't know the literature that underlies that. It's been something since I was a junior doc on intensive care. We've always done that. I'm sure there's literature out there, and maybe it merits a study. Because
when we give the norepinephrine infusion, we're giving a naturally occurring substance to replicate the levels that happen if someone drives out in front of your car. So every time you have that oh my god moment or get excited watching a sporting game or something else, the amount of norepinephrine inside your vein is at the levels that are achieved in the bloodstream, but it's the concentration where you put it in is what they're fretting about. Is that?
I guess it is. One could make the case that naturally it is given centrally.
Yeah, good point. There we go. Got us on that one. But why is the dopamine okay then? Because it's a precursor for norepinephrine. Anyway, I think we need to sort this one out.
They're great questions.
So I think we need to sort it out because a lot of people are shying away from using vasopressors and therefore giving a lot more fluid. And the literature is suggesting we need to get the fluid right. Then in about 20% of patients who are older and frailer, the addition of the hemodynamic agent helps. Now, if going back to dopamine, which when I was young, we used to give the so-called low-dose renal dopamine, which one of the reasons it was criticised is it essentially becomes a norepinephrine infusion. That when people measured blood levels, they said you've got to stop doing this because the norepi's going up. Maybe that is a simpler route in to getting people to reconsider the earlier use of vasoactive agents in some circumstances.
It's a possibility. Again, I just think that I actually disagree that people are reaching for fluids more. I still feel like I mean in our practice and other practice that I see, people will just always reach for the first stick in front of them. Blood pressure's low, I must treat it. So I think changing the idea of how we treat is going to be the education point.
Right.
I think Optimize was very interesting from this perspective for me in that, so relatively high-risk patients, the intervention group had an infusion.
Yes.
Whereas the control group, who you'd expecting to not be getting these types of drugs, in fact, around 90% of them were getting boluses. And I think it probably makes a lot more sense to infuse something at a reasonably steady rate than to keep just popping boluses in from time to time.
But further with clarity on that is the infusion, whether it's the norepinephrine infusion or a dopexamine infusion, they both have some chronotropic effect, whereas the stick tends to be a pure alpha.
Yes.
So that needs to be picked apart as we progress. Well, we need to rush to the opening of the first session. Lots of exciting stuff happening today. We'll be reporting back later on. Desiree, Mike, thank you very much indeed.
Top Med Talk.